The muscle examination is critical in the evaluation of a wide variety of patients, athletes, and clients. Together with the history and general physical examination, an assessment of muscle strength can inform your evaluation of athletic performance or your diagnosis of weakness or motor impairment. In this lecture, we will outline an introduction to and practical approach for assessing muscle strength. This approach is designed for the patient presenting with complaints of weakness or in whom weakness is suspected. The assessment of strength in an athletic or competitive setting will not be discussed. Laboratory and electrophysiologic studies of nerves and muscle biopsies are often required to complete the evaluation of impaired populations. However, these too will not be discussed. We will elaborate on a method of muscle examination that can be performed easily by the clinician in the hospital or clinic setting. The evaluation of an individual presenting with a complaint of weakness involves 3 steps.
The first step is to confirm whether there is true muscle weakness, or whether the motor impairment is due to fatigue, pain, or stiffness, rather than loss of muscle power. Once this has been established, localizing the site of weakness within the neuromuscular system can be undertaken. Finally, the cause of the lesion should be determined. Serial or repeated measures of muscle strength and function are necessary in the long-term follow-up of patients with neuromuscular disorders to determine response to treatment. Please note, examples of conditions that may cause muscle weakness are described. However, these are not part of learning outcomes for this lecture and are for demonstrative purposes only.
For the purposes of this lecture, we will be focusing on the second step, assessing and localizing the strength of a specific site or group of muscles. The methods that are described here, while useful clinically, may not be widely adopted in research settings because they are not the most valid or reliable. However, what they sacrifice in validity and reliability, they make up for in clinical utility.
Specifically, more formalized, quantitative and semi-quantitative systems for measuring muscle strength and function have been developed for use in clinical trials. But these are often unfeasible to implement in the clinical setting, whether because they require costly equipment, necessitate significant expertise to operate, or take too much time to perform.
Furthermore, in this lecture, I will only be outlining the general principles of evaluating muscle strength. More detailed descriptions of testing of specific muscles is available in comprehensive manuals of muscle testing, and we will be discussing some of these in the body site-specific lectures of this module. When localizing the strength of a specific site or group of muscles, the examiner should follow a systematic approach. As we previously discussed in part 2 of the lecture on posture, this is to maximize the reliability and validity of the measure.
This systematic approach includes the following steps: inspection of muscle, palpation and percussion of muscle, manual muscle strength testing, and assessment of motor function.
Joint examination and neurological examination, including testing of deep tendon reflexes and sensory testing, are also important adjuncts to the muscle examination and motor function, but they won't be elaborated upon here.
Let's begin with the inspection of muscle.
Inspection or observation of muscle may provide important clues to the etiology of muscle weakness.
Localized atrophy may be seen as a result of either localized disuse, secondary to joint disease or joint pain, or of lesions of the central or peripheral nervous systems. Examples of joint disuse or joint pain include quadriceps atrophy, associated with chronic knee pain, and examples of lesions of the central or peripheral nervous systems associated with localized atrophy include thenar eminence atrophy due to compressive neuropathy of the median nerve.
The degree of atrophy, as well as a general assessment of the size and musculature of the individual, should be noted as a basis for the subsequent formal testing of muscle strength. Another possible finding on inspection of a muscle is the presence of fasciculations. Fasciculations are due to spontaneous firing of motor units and may be observed in normal individuals, particularly with fatigue, or may be a sign of motor neuron disease. Benign fasciculations tend to be more widespread than those due to motor neuron disease, though. The lack of accompanying muscle wasting or weakness and long-standing duration also favour the diagnosis of benign fasciculations.
Next, we'll move on to the second step in our systematic approach to evaluating muscle strength: palpation and percussion. palpation and percussion may provide helpful findings in your evaluation.
A good example of the utility of palpation and percussion when evaluating muscle strength or weakness is the increased muscle tone or rigidity that is present in Parkinson's disease, a disorder in which weakness or decreased motor function may be an initial complaint.
Next, we will move on to the third step in the systematic approach to strength testing: manual muscle testing. The Medical Research Council's grading system for muscle strength is widely used, and that is the system we will adopt in our practical class.
In this grading system, the examiner assesses the patient's or client's ability to move the muscle against resistance. This resistance is provided by the examiner who, through experience, has developed a sense of the expected range of normal. This obviously has implications for the validity and reliability of the measure, and will vary from patient to patient depending on their underlying size and conditioning. The fully trained athlete obviously can be expected to perform differently from a small, sedentary, or a deconditioned individual.
In this grading system, the patient's effort is graded on a scale from 0 to 5. 5 means that the muscle contracts normally against resistance. A grade of 4 implies that the muscle strength is reduced, but a contraction can still move the joint against resistance. A 3 is where muscle strength is further reduced, such that the joint can be moved only against gravity with the examiner's resistance completely removed. As an example, the elbow can be moved from full extension to full flexion, starting with the arm hanging down at the side and the patient in a side-lying position. A 2. The muscle can move only if the resistance of gravity is removed. As an example, the elbow can be fully flexed only if the arm is maintained in a horizontal plane. A 1 is where only a trace or flicker of movement is seen or felt in the muscle, or fasciculations are observed in the muscle.
Finally, a 0 is where no movement is observed. This system was initially devised to evaluate trauma victims with rhabdomyolysis and is weighted toward the lower end of the range of strength spectrum. It is relatively less sensitive for the evaluation of mild weakness, which is the usual range for patients with myopathies.
It is important to note that this semi-quantitative analysis of muscle strength relies on the full effort and cooperation of the patient. Thus, patients who are unable to follow instructions due to cognitive deficits or decreased level of consciousness cannot be tested. Decreased effort because of pain, fatigue, or malingering may be identified by give weakness, in which there is initially a full effort followed by the abrupt loss of strength against resistance. This type of response does not occur in the truly weak individual.
If intentionally decreased cooperation is suspected, observing the patient performing simple functional tasks, such as sitting up from a supine position or toe or heel walking, may reveal a discrepancy compared with the patient's performance on directed muscle strength testing. We will cover some of these practical tests for muscle strength in our practical classes.
Finally, we will move on to the last step in our systematic evaluation of muscle strength: assessment of motor function.
The assessment of motor function involves simple functional tests that, while often unsuitable in providing insights into the strength of a specific muscle, give us an idea of how someone copes with performing activities that they would normally perform during their daily lives.
These simple functional tests can be performed in the office and may be tailored to the individual patient's clinical setting. We will cover some of these in the body site-specific lectures. However, as an example, these tests might include observing the patient rising from a seated position without the use of hands, or sitting up from the supine position on the examination table, climbing on and off the examination table, performing serial deep knee bends, elevating arms above the head, or lifting a weight with an extended arm to eye level.
Observation of the patient during toe and heel walking is an easy way to assess dorsiflexion and plantar flexion ankle strength.
The 6-minute walk test can be easily repeated and followed at serial visits.
And that concludes this lecture introducing you to the evaluation of muscle strength. In this lecture, we introduced you to the clinical insights that can be garnered from an assessment of muscle strength. We then outlined a simple practical approach to assessing muscle strength, one that you will likely use in the clinical setting.